Welcome everyone. This is Patricia from the International Hospital Federation. Thank you for joining us today in our webinar, Value-Based Healthcare, How Dental Health Services Victoria is Transforming Oral Healthcare. This webinar is being presented by Dr. Deborah Cole, CEO of Dental Health Services Victoria, and Dr. Zoe Weiner, Board Chair of Dental Health Services Victoria. Deborah has held the role of CEO at Dental Health Services Victoria since 2011, where she has worked to significantly improve the community's access to quality and equitable dental care. Prior to joining DHSV, Deborah held numerous leadership roles as the CEO of the City of Yarra, Director of Health Support Services at St. Vincent's Health, CEO of Calvary Healthcare, Executive Director of Health Services at Mercy Health, and non-executive director on the Dental Practice Board of Victoria. Deborah is board chair for the Australian Healthcare and Hospitals Association and a board director for the Hassel Care Foundation and HESTA. Zoe is the chair of Dental Health Services Victoria, the head of public health and medical director at Bupa Australia in New Zealand, and is a director on the board of the Victorian Responsible Gambling. Her passion and expertise in public health has driven formal and informal collaborations with the ICHOM and Harvard Business School in value-based healthcare across multiple organizations, and she has a continued advocacy focused on the importance of sex differences across health from basic research to health systems implications. Zoe holds a Bachelor of Medicine, Bachelor of Surgery from Flinders University, and has a clinical background in cardiothoracic surgery and thoracic surgical oncology. She has a PhD and a Master's of Public Health from the University of Melbourne and is a graduate of the Australian Institute of Company Directors. Deborah and Zoe, thank you very much for joining us today, and we look forward to learning how DHSV is transforming oral healthcare.
Thank you very much, Patricia. We are really happy to speak to you all today, and we're going to spend about the next 30 minutes talking about our journey and really look forward to having some questions from people going forward. So I'm going to pass first to Zoe and start the process going, or the presentation going.
Thanks very much, Deb. Well, we thought we'd start this webinar with actually talking about what we mean when we use the word value-based healthcare. It's certainly a term that gets used extensively around the world in healthcare at the moment, but we thought it was quite important to define that first up because it is our true north. And we're using the Harvard Business School's definition of value, and that is the health outcome that matters to the patient, and that's absolutely crucial, the matters to the patient bit. Over the cost of care. And certainly in Australia, sometimes when we use cost, we actually talk about funding, but in this situation and this equation, we actually mean cost. So to improve the value, we either have to increase the outcome, decrease the cost, or do both. So how did dental health services get here, and what's our value agenda? We started this journey in the public oral health sector to improve health outcomes with the scarce resources that we have. This started about 7 years ago with work in what we call models of care, thinking how we might deliver care differently. Then when I joined the board, we undertook a new strategic plan with a strong focus on life course and prevention. And soon after that, I and the CEO worked with the board on developing how value-based healthcare might be the way that we actually deliver that strategy. So if we had to sum up the aim, it's to achieve the best health outcomes at the lowest cost. But it's really important to point out that this is not about cutting costs to meet a budgetary bottom line. It's about determining the most efficient way to deliver good health outcomes that matter to patients first and foremost, and then carefully considering who in the team is best placed to do that. It's about creating a system that is person-centred, truly person-centred, designed and co-designed with consumers so that we understand what services are right for them. It's about providing the right services by the right clinician in the right location at the right time. And it's crucially about creating a workplace culture that supports transformation, because a workplace that feels valued and respected will support the change journey and understand the vision. And it's about integrating care. So we want to get rid of the single illness episode, which is built in a silo, and look at the patient journey across their care. I think it's also just important to note at this point in time that our presentation is very focused on the Australian public sector, but it is applicable in private settings as well. And there are many examples of where value-based healthcare is being trialled in private healthcare across the world. So it's not just the people eligible for the public sector that avoid seeking care due to cost. We know that. It's also those who would potentially access the private sector for whom this work is really important.
So the next thing I want to talk about is why did we actually think we needed to change the way we were providing oral health care? And a lot of people say we've been doing it the same way for a long time. Why change? So I'm going to take you through some of the whys about that because it's really important to think about it. And this slide that we have up now is when you look at a lot of value-based healthcare presentations, this will be the fairly standard sort of slide that you get to see. And it's basically from a healthcare system perspective. So they talk about the fact we've got huge population growth, we've got ageing population as well. So you get all the comorbidities associated with that. So lots of increasing chronic disease. So we need to move from that view that we can cure everything to the fact that we have to care for people with all these comorbidities. We also all have to deal with rapidly evolving technologies and new medical knowledge. Our consumers are expecting a lot more, and rightly so, and we need to be able to respond to that. They need to be major players in the actual decision making. And one thing that's pretty clear across the world, and it doesn't matter in which health discipline it is, there is huge quality and quantity variations across the sector, and particularly in health outcomes, but also in the health inputs. And all of these things give rise to increasing costs. And if you look at most graphs of health expenditure as a proportion of GDP across any country, you can see it's rising pretty rapidly. And none of us can sustain that into the future. And if you look at, you can look at healthcare variation in a number of countries, and you can look at it in Australia. But one of the things that we did was look at replicating that same sort of variation information across the dental sector. And this is looking at Victoria in the public sector and just looking at it by local government area. So that's what the LGA stands for. And so what we're doing is just looking at the huge variation across the state. Now, this isn't to do with socio-demographic differences. This is just pure variation that's probably provider initiated variation. And when you see this sort of variation, you realise how much waste is in the system. And if we could, while I can't tell which one of those is, where is the best health outcome, what I do know is there's enough variation there that if we could transfer that variation to other people, the care, we would actually significantly improve the health of other people, many more people than we currently do. So variation is a very, very significant component in the healthcare system. The other thing, and this is a graph or a diagram that's been taken, basically it was sort of produced for New South Wales, but you can see here that it's very clear that just because you spend more doesn't mean that you get better health outcomes. And while I'm not sure whether the little photo boxes up in the right-hand corner cut out the price, but right up in the far right-hand corner is the United States. And they spend a lot of money and don't get good health outcomes. And you can see in this situation, New South Wales is probably one of the best in the sense of producing it. But Australia is right there with getting much better outcomes for its expenditure. But we could still do so much better, and you can see from that previous variation graph. So spending more money doesn't mean that you get better health outcomes, and I think that's an important thing to remember. So when I started using these diagrams about the why before, I only used the system one, and I found that a lot of the clinicians and the people, the workforce that worked in the organisation, it just didn't mean anything to them. And so I started to ask and talk to a lot of the clinicians about, why would they want to change? What, is there any reason for them? And the overriding thing we get from clinicians, particularly people that have been working for a long time in the area, is that they find that they keep doing the same thing over and over again, and they're not getting improved health outcomes. They find it really frustrating. They actually want to improve health outcomes. And they find that they're getting people just coming back with the disease, getting worse and worse and worse. And we look at all the data about DMFT over a period of time, or decayed, missing and filled teeth over a long time, and can see that it just gets more and more and more. And in fact, most of the diseases we deal with in dentistry are preventable. So it is pretty frustrating to clinicians that they are not making a difference, that they're not actually concentrating on that preventive cycle and some of the population health type interventions they can support and advocate for. And as a result, they're finding that they're unable to deal with all the care. And they're finding that the waiting lists continue to grow, and often with people that have been coming in before. So it's a pretty frustrating environment for them. So the next people we thought we need to talk to, and the most importantly, is our consumers, and not only the patients that we see, but also the people that are eligible to see us but don't come and see us. And so what we wanted to do was to make sure that we could speak to them and ask them. So we spent a lot of time talking to our consumers about what changes that they would want. And one of the things that was pretty clear when talking to them is, while they might enjoy coming and see us in some ways, they actually don't want to come and see us, because that means they've got problems. They actually want to enjoy life without being affected by poor oral health, or poor any type of health, actually. And one of the things that they would like to know is, what could they do to make it better? How could they avoid seeing us? How can they be supported to make good health choices? And while I recognise that not all patients think like that, a vast majority of people, when we spoke to them, they were pretty clear that this is what they wanted. So they wanted to be active in the decision-making process about their health, and they wanted to be listened to. They wanted to be seen and heard and respected, and they wanted us to help them with their care and coordinate it. Doing it with them, not to them, was the sort of thing that they wanted. So pretty strong messages about what it was. And the other thing we got from them too is, why do we always have to come to you? Why can't you come to us? And in some situations that's possible. So it sort of forced us into thinking very differently about the way we might provide services into the future. So the big thing then was we needed to change. We had agreement from all of our major players, the government, our providers, and also our patients and consumers, that we needed to change. So we had to work out what we needed to do to start. So just to put this up was, we developed what we called a war room. It's not a very nice name, and in fact we at one stage tried to call it the Harmony Room, but that just didn't work. And so what we ended up with, what we called a war room. And what that was we took one room and set it up totally as a value-based healthcare room. It was a dedicated space. And that meant that people could, whenever they went in there, they got to focus on value-based healthcare. The whole room is totally covered in post-it notes and plans and project plans and ideas, etc. So it was a very visual space to go into, and people could come in and add things to it. They could move things around. They could have discussions. No one was allowed to go in there for any other meetings unless they were associated with value-based healthcare. And our consumers could go in as well and contribute to the whole process. So it was a space where people could really concentrate on what we needed to do going into how we planned. They could dream there, they could challenge and evaluate. And that's for all people that are involved in that patient journey. And we found that that made a really big difference. And in a hospital where we were doing it in, finding one room that you could spare is really, really hard to find. And so this was a really important thing for us, was to have a room that was just dedicated to value-based healthcare. So what did we do? The first thing we did was we looked at the Harvard model. And as Zoe said earlier, we we had already been doing some preliminary work, and we had had a public public health model of care, and that probably hadn't really grabbed the hearts and minds of all the people that had to apply it. We had a strategic plan with a really strong health outcomes focus and great experience focus. And then we decided that value-based healthcare was the pathway we would use to deliver it. And so we went to a document by Porter and Lee, so Michael Porter and Tom Lee from Harvard, that was called The Strategy That Will Fix Healthcare. And in there, it's not a very long document, it's really well worth reading. And what it does is it almost steps out how you set one up, how you go about the process. And you can see the shadow part of it on the left-hand side of your screen. But they had 6 things that we needed to follow through and undertake. And we took those 6 things and expanded it out and developed our framework, our value-based healthcare framework, which you see up on the screen now. And that was pretty important. And this is probably about the 4th version of it. So we have adapted it over time as we've learnt and discovered that we might not have picked up on everything as well as we could have. The really, really important thing about it is the centre. And the centre is the most important people, the consumers and our workforce. And it is about a really strong co-design and engagement model. And that's challenged us all because we have to all work together. And we've had consumers involved with it all the way through, right from the very, very beginning. And so we've looked at all the things that we needed to do. The first thing when we got into our war room, which we talked about to do, was we needed to map how a patient currently went through the system. And then we need to design what we thought the future state would be. In fact, we went to an ideal state, which was there were no constraints, and then went to a future state. What should it look like in a couple of years' time? And worked with both patients and our staff to develop up what we thought would be the ideal way forward. So there's a lot of lean thinking in there. There's a lot of appreciative inquiry, and there's all different techniques we've used to get to that stage. And on this wheel that we have here now, each of those wedges has a huge body of work associated with it. And the far right-hand corner is actually the model of care. And there's 2 components to the model of care. There's the individualised interventions, which is what happens in the clinic side of it. And from that, we have really well documented, that's where all the clinical guidelines go, you know, what types of materials we'll use, etc. And in that, we are documenting a really strong prevention, early intervention, minimal intervention type philosophy. And on the next part of it is that we have population-based interventions. So obviously strong advocates for water fluoridation, but also a lot of settings-based interventions. And in the long run, we imagine that when we are looking at the value equation, we will apply it to the population health interventions as well, so that we know that by undertaking that particular intervention, we're going to improve health outcomes at the best cost. So I think in a public setting, you need to have both of these components really clearly articulated in your model of care. Other things is culture and capability. It is important that you've got really strong cultural work happening. People need to want to accept it. Not everybody does. And you need to give people the capability, because you have different people doing different work. That's a really major component of it. And you often have to make sure that people have got the skills to do that. We need to measure outcomes and costs, which we'll talk about a bit later. Funding models have to be developed. We need to have really good data collection, and there's good integration both within the oral health services, but also within general health. Great ICT platforms are required, and sometimes you'll need infrastructure changes as well. So there's a lot of work on this slide, and it is the framework we use for going forward. I said before that it was really important to create a culture, and while I'm not going to go into this in a lot of detail, one of the things is this is where we imagine it to be when we are fully finished, is that we'll have a workforce that's really fully onboarded, and we're already doing a lot of that now with people as they go into a value-based healthcare environment. They are put through a very, very significant onboarding process, and they're supported to do their job well, because quite often I think we tend to see people, they've got a qualification and we throw them into the clinical environment and expect them to by osmosis pick up what the new guidelines, etc. are. So we've gone very consciously down the track of making sure that isn't the case. And we want to make sure that people are working together and engaged and work as a team. And so we've set up quite a strong system where we call it DHSV, a respectful workplace, which is a whole set of strategies to help people to be the very best they can be at work. So one of the things I said is we're also working on developing oral health outcomes to measure oral health. This is probably the first body of work we probably started doing, because we quickly realised we didn't have a lot of health outcomes to measure whether we were successful. So we, along with HCF Foundation in Australia, and also Harvard Dental School in the United States, co-funded the development of our minimum data set, health outcome data set for oral health. And it's very imminent for publication, but this is just showing you some of the documents that exist in other health minimum data sets. There's quite a number of them across the world, but that has proven, it's taken us 2 years to do that, but it's been a really worthwhile exercise. We've also done it in combination with the International Dental Federation, which means that it's got the imprimatur of dentists from every country in the world, which has been fabulous. So I think that's going to be a really, really useful document when it comes out. We've already started using the measures that have been developed for measuring our patient-reported outcome measures. The other thing that we're doing is developing a new funding model. The type of funding that we have at the moment is based on a fee-for-service type model. And so that drives behaviour of producing volume. So one of the important things about value-based healthcare is to move from volume to value. It's about improving health outcomes at the best cost, but it's not about just doing the volume part. And our current fee-for-service models do tend to drive that. So we are in the process at the moment of developing up a funding model that will have incentives to improve health outcomes. So the idea is that you will get paid to improve a health outcome rather than to do lots of things to people. Because I think right across the health sector, there are a number of health activities that we undertake that actually don't improve the health outcomes of the people that we provide them to, and we need to remove those from our health system.
So thanks, Deb. I guess reflecting on what are the lessons we've learned so far that we can share with all of you. Firstly, I would say that leadership is critical, and leadership doesn't just mean the obvious leaders of the board and the executive, but it means every member of the team, and crucial to that is clinical leadership. And I think the other thing to say about leadership is that implementation takes time and it takes commitment. And as I said, leadership is certainly not confined to the board and executive. It actually has to involve the whole organisation. So the cultural element is key there. I think the next point is outcome measurement is a team effort. So all stakeholders need to be involved in the process, and involving consumers is absolutely essential in building our capability in that space. And I think it's important to think about what we're going to do with the data and how do we make it accessible to the people who need to be able to see it. So crucially, our clinicians and our consumers and patients. As you've heard us say several times, culture drives success. So the values and matched behaviours are absolutely essential around value-based healthcare. And busy people find it really hard to change and reform, but supporting people with the right behaviour is vitally important. And identifying exemplars who are not only willing, but really engaged to champion the change is really important in that. I think the first step is often the hardest. We actually had a chance to talk with Professor Tom Feely at Harvard when we were just beginning, and he said to us, just start. Doesn't matter if you get it wrong, but you just have to take the first step, because we were quite paralysed at looking at the whole body of work and thinking, where do you start? And there will be lots of barriers along the way. You just need to find a way around them and push on with that vision in mind. But begin with the understanding that the system will be imperfect and work to improve it over time. We have very much an iterative process, and sometimes we fail. And as long as that's not about competence, that's absolutely fine. That means that way doesn't work. We reiterate to find the next way, the better way forward. And I think co-creation with consumers actually needs skill and practice. It's an idea that's used a lot. Health providers have always designed health systems, but we actually now really genuinely want to share the role of designing that system with consumers or patients. And that can be quite scary, and we're going to make mistakes on the way, but that's okay, because our consumers are actually very forgiving and generous, because they understand that we're doing this with the intention of helping them have the best health outcomes possible. And our patients have to be actively involved in the design, not just reviewing the designs that we develop along the way. Our consumers can stand up actually and give the very presentations that Deb and I do. They've been so involved in the process. Next slide, Deb. So I think we had a little bit think about what is the future state for the system, and really that is looking at what improved outcomes look like at the lowest cost. So the future state is measuring outcomes and understanding the drivers. The system is enabled, not hindered by technology, as so many of us experience today. We spend time and resource on prevention and early intervention, and that will change what the case mix of our healthcare looks like. Consumer expectations are managed and are actually being met. We're addressing the unwanted variation that Deb spoke about earlier, and we're able to care for more people, and we understand what the cost of that care actually is. And the funding models that we have across the system actually incentivise the improvement of health outcomes. So we like to finish on this quote because we think it really brings home the thinking that I marvel that society would pay a surgeon a large sum of money to remove a patient's leg, but nothing to save it. Thank you very much.
Thank you, Deb and Zoe. We'll start reading some questions from the audience shortly. Just to remind everyone, you can send your questions by typing them in the Q&A tab, and we'll try to address all of them in the remaining time that we have. All right, so we have here some questions. So first one is, once you determined your value-based healthcare framework, what area did you start with?
That's a good question, because as you, I think Zoe said, that when you first get started, you sort of think there's so much to do, which area will you start in? And some of it, I think you just have to be a little bit opportunistic, or look at what is the thing that's really going to make it or break it. And for us, it was, we didn't have any health outcome measures that were acceptable. So we thought, we better get going on that. And while we thought it would only take a year and it's taken 2, it was a really good thing to start with. And when we got involved with ICHOM, we actually got to meet lots of other people that were doing things, and that sort of snowballed to the fact we've got to meet other people and leverage off some of the work they're doing. So once you get into the value-based healthcare family, I suppose, it sounds a bit scary, but when you get involved with everybody, you find that you can leverage off and learn from other people. So we started with doing the ICHOM work, and then we went, the next step was, let's sit down and do our mapping. So we actually went through and value mapped, so the patient journey, to really understand what was required.
I think the other element was, and I remember this moment vividly, where we were trying to work out what an integrated patient unit, which is one of the elements in value-based healthcare, looked like in dental health, because it wasn't, we couldn't actually mirror what an integrated patient unit, say in cancer or in heart failure, looks like. And it was Tom who said, just start, Tom Feely. And so we actually decided that general dental was an integrated patient unit in our environment. So it's about thinking a little bit laterally, I think, when your healthcare settings don't necessarily perfectly match that Harvard framework.
And in fact, one of the things that in discussions I've been having with people around the world now, while we went about it using that Porter and Lee document as our map, a number of people now are starting to just look at variation to start with. So start getting your data and looking at variation in what you're doing, and then going, well, where there's significant variation, starting to have conversations about, well, maybe what should be the right level, and then what can you do about either reducing it, recognising that some people might be so low they're not providing enough of that service too. So you get both ends of it. But just mapping variation can make a huge difference, and having clinicians having discussions about what should it be, what is reasonable, is a very, very valuable thing in starting the journey as well.
Thank you, Deb and Zoe. We have here a question. Do you have any advice for how to introduce outcomes for generalist care rather than for specific conditions?
For generalist care, in some ways what we've done is for generalist care. We haven't done it for specialist care, but you're right, most value-based healthcare is about a particular condition. And I know that ICHOM are doing some work at the moment of developing a standard set for adults and for children, with the view that you aim to be healthy and well rather than unwell. And that might be actually where the generalist side of it comes about. But I think that's actually something that people are working on at the moment. In some ways you can sit down with consumers and go, well, what would be the health outcomes that we would want to measure from a generalist perspective? And I look at some of the things that we are going to be measuring for oral health. And in some ways you could just leave off some of the oral words and they would be the sort of measures that you would use. They're things like, can you interact in society? Can you talk? Can you eat? Are you living without pain? All of those things is basically, are you participating in the community well? And I think that over time, I could imagine that we will end up with a pure set of generalist type indicators, or a standard set that just about everybody will use, with a couple of specialist things added on for special conditions.
Thank you, Deb. A question here is if you can share more details about the funding model that you're developing.
It's very early days because we've just started the process. So the first thing we've done is done a literature review and looked at who's been doing it around the world. And to be fair, not a lot of people, although it is growing. And in fact, we've been in contact in the last few days with people in France and the UK who are doing work at this moment. But the sort of where we think we will be going is ending up with a blended payment model, where there would be a component that is for a capitation payment, which pays for the population you're treating. And then on top of it would be a payment for the value component. So if you improve health outcomes, then you would get an additional payment on top. What we are still grappling with is how do we manage those high cost, like prostheses, or which would be equivalent in general health, but the things that you have to buy in. So in dentistry, that's a lot of laboratory work, because you want to make sure that you don't incentivize people to do that because they make more money out of it, but you don't want to disincentivize them if in fact it improves health outcomes. So that's the sort of thing we're looking at the moment. But early days, and in about a year's time, maybe we can answer that. But our intention is to develop the model and then shadow it for a period of time with our current funding model to see how it goes. And we've got very good support from our government to allow us to do that.
And I think it's worth saying we're looking more at how do we incentivise good health outcomes and punish the non-delivery, so more the carrot element than the sticks.
Yep.
Thank you. We have here a question from Dr. Jaren from India. Do you have some lessons for learning on medical error reduction and its impact on value-based healthcare? For example, how to substantiate spending on safety measures to reduce errors, assuming that absolute error reduction is impractical.
Yeah. Some of the data pieces that we have to collect as part of a health outcome is to do with medical error. So in fact, if you have a lot of error, then obviously you're not going to be adding value. We know that there's right throughout the health system, not just dentistry, but there is a lot of medical error. And in fact, that's one of the significant costs to our community. And reducing that is pretty essential in this process as well. So the important thing is to pick which of the data points that you would collect in that would make a difference, and incentivize people to do it. And part of, ideally, when you're planning the patient journey, etc., you take into account the things that you want to reduce those never events, and plan a process for how to do that. So from what I've seen, you can make some pretty significant differences to reducing medical error by doing that, going through that process. And I've seen that in other disciplines, not so much in the oral health one, but we're just early on in that stage. But so a lot of people now get to the stage where you certainly don't. I mean, one of the important things I think, particularly with our fee-for-service type model, is we often get funded to fix up our medical error. And there would be some people would be saying that that's probably not a good thing to be doing. In fact, it incentivizes. It doesn't give you any disincentive for the medical error. Not that I'm saying that people actually choose to do medical errors, but if you've got a lot more incentive to make sure it doesn't happen again.
The other thing to add to that is the strategy behind the thinking when it comes to data collection with the iCHOM data set and Harvard Business School's model is that you collect data that matters to patients, you collect data that matters to clinicians, and you collect data that matters to the payers, because they are the three key stakeholders in the system that we want to incentivise in the right direction. And so to answer that question to some extent, the Martini Prostate Clinic in Germany is a really good case study because they use their data in two ways. Firstly, they use it internally facing, identified at the clinician level, so they can pick up when people's when clinical practice is going a little awry. So they use the example of the director of the unit started to get positive resection margin on his prostate cancer. They could pick it up very quickly because they reviewed this regularly and as a clinical team, and he then retrained with the person who had the best outcomes. So it was a very real-time way of picking up that medical error. And then they use the data externally facing to demonstrate what their outcomes are as a team when it comes to the issues that matter to patients. So that's another way that it's addressing medical error is inbuilt into the strategy and the process.
Thank you, Deb and Zoe. We have a question here from Cindy. She says, one of the main elements of Porter's value is looking at the specific model condition over the full cycle of care. How have you approached this aspect in dental health care?
Over the whole cycle of care. We have our whole process now. In the past, the way we provided care was in fact episodic. And now the process that we are looking at is it is over a whole cycle of care. So the intent, which because it's a chronic disease in some ways, it's for life. And one of the things we want to do is to make sure that we get people into a managed state so that they can be seen less and less, but may have touch points, and we call it check-in points rather than checkups, which we often do in dentistry. And give people an opportunity to come back in if they're feeling that they're losing control of their own health management. Because it is so preventable, that's the tack we're taking, but it needs to have a lot of self-management from the patient as well. Hopefully that answered that question.
Well, and part of the process that we go through is the first interaction with us is actually setting in place the preventative measures that they need to do for the whole of the life of their teeth. And so that's actually setting up the good behaviour in the first place, and then we can address the illness or chronic illness elements as we go along that process.
Part of our model of care has something we've never done before, but other disciplines have, is we bring all of our patients into, or not all of them, but in a group session where we explain what's going to happen, what they're going to go through. We give them, as Zoe said, all of the information about how to maintain their own oral health. But we've sort of realised that quite often people come into the health system, into the dental system, and they've got no idea what we're going to be doing to them or why we're doing it or anything. It's not well explained. So they sort of arrive and they just get moved around the system without really knowing what's going on. And we found that what we do is we're running these introductory sessions now, making it really clear about what's going on, giving people opportunity to ask questions and then come back later. And we're finding a huge improvement in our attendance rates as a result. We still sometimes don't get people have the same lack of attendance at those group sessions. But once they get through that and come into the clinic, we're getting very high attendance rates. And it's a much more, once again, it brings the value equation into place. It's a lot lower cost not turning up to a group session than it is to a full clinical session where you're wasting quite expensive time within the organisation. But we're finding that the feedback we've got from our patients is they just feel so much more relieved. They know exactly what's going on, what their responsibilities are, and what we're going to provide care for them. So it's proving to be quite a important thing. It looks a bit over the top at the beginning, but I think looking at some other more primary health type models of care with value-based healthcare in non-dental settings, there's often an upfront investment, and then you pick up the savings later on. But we're finding we're getting savings even straight up front, just because we've got two things in place. One of them, we've reduced the fail to attend rates, but we've also changed who does things. So we have the people working to the top of their scope of practice, and different people doing different parts of the work, which traditionally would have just been done by a dentist.
All right, everyone. Sorry, but I think there are some technical difficulties with Deb and Zoe's audio. So I will just be sending the questions to them. They will be reading them and answering them one by one with the remaining time that we have.
So many, I'll just read the question out and then we'll try and answer it. So many institutions or hospitals seem to be heading towards an acute care focus in terms of investment resourcing. How will value-based healthcare fit in with this moving forward when much of the current treatment in these institutions is currently focused on treatment of chronic conditions? I think the response to that would be, I think most jurisdictions, particularly in Australia and in other countries, are really aware of the fact that an acute focus is not the way to go. And they see value-based healthcare as being the tool to allow that to happen. And so that's often why the funding models are really important, because at the moment you get funded for an acute episode or for an outpatient episode or primary care episode, and subacute type episode. And the problem is that that's not helping the person improve their health outcomes. So there's quite a few models around the world now that are being tested, actually looking at that whole continuum. And it's one of the reasons why we were quite interested in doing this in the dental space, because we do look at the full continuum. We do the population health interventions, but we also do primary through to tertiary. And because we've got control of the funding in those different areas, we can actually look at how do we do this. So we see this as potentially being a model that can be used in general health setup. You want to add anything to that? Yeah. So I think the value-based healthcare is seen very much as an opportunity to get over the problem that's addressed in that question. The next question is, in relation to the process of organisational transformation, what were the cultural characteristics of your organisation prior to moving to value-based healthcare approach? And what are you aiming to move towards, and what has been the most effective in bringing about cultural change? Look, like a lot of organisations in health, we're very hierarchical, and to be fair, we probably still have a lot of that there. It's a very, very hard thing to do, is to change that hierarchical structure. value-based healthcare works much better when people work as teams. And so, but if you've never worked as a team and never seen it done well, it's really hard to give up the power that goes with the hierarchical transformation. So we've been running a program for about 2 or 3 years called the DHSV way. And what it is we've got, when the board designed their new strategic plan, they also adjusted the values for the organisation to reflect the fairly transformational change that they were expecting. And so what we then went through and worked with all the staff throughout the organisation and with patients as well, as to what would the behaviours be like that go with those values. And that takes a long time to do. It takes a lot of discussion, and sometimes it's a bit scary when you see people talking about the values, what behaviours, because often what you think might be acceptable, like the appropriate behaviours, are not what they think they are. But the discussion is the important part of the process. So it isn't something that happens overnight. Getting the right sort of culture is really important. So one of the things we do is we often do lots of sort of behavioural testing of people before they get accepted. So we do a lot of employment programs now to make sure we get the right people coming on that want to be part of a system going forward. And that has proven to be very successful. And we're finding that we're getting a lot of people now that are really enthusiastic about the change. That's not to say that everybody is. But sometimes everybody has a place that they can work in, that they can add value to, and you need to find that place for them. You know, what are the things that they like to do? What are the things that they can add and contribute to the value equation within the organisation? So the organisational transformation is midway. We're not there yet. And in fact, you often, one of the things I think it's worth saying is when you go through that process, people will become unhappy before they become happy, because the change is reasonably significant. We call behaviour if we don't think it's appropriate. And you often find that once you say that you'll do that, then people like to test you, that you will call it. So you end up being overwhelmed by people testing you. But that's okay too. You just have to accept the fact that's part of the process. So the next question was, what reaction, positive and roadblocks have you received from state and federal agencies regarding a different approach to healthcare? Look, to be fair, we've been overwhelmed by positive support from both federal and state players. I mean, I think, to be fair, there's a few people going, you beauty, that's fabulous. There's somebody here who's at the forefront wanting to do this. But they have been, the state government has supported us financially to go about this process. And initially we started to do it without any financial assistance, mainly because we were really aware that we had limited resources and we had a view that we could do better with them. So it would have just taken us a lot longer, but we would have got there. But now we have support from the state government, which is helping, and a lot of federal agencies have been talking to us about what we're doing, really keen to hear about what's happening, understand the process we're going through. In fact, in some ways, I think most of them would like us to do it a lot quicker than what we are, but there is only so many things you can do at once, so we just have to go through the process and then start publishing the outcomes. So the next question was, what has been the most useful in redesigning your service, and what modifications have you had to make for the Australian setting? From a modification point of view, I think that the value-based healthcare model is applicable in any country. I don't think it needs to, you just always have to take it and apply it to your setting, which is what we did. And it's not just the Australian setting, it would be the particular organisational environment you're in, the policies that exist. Like we know we'll have to work with government to change some of the government policies about things because it was designed around our current models of care, and many years ago too. So, and nobody has said, well, you can't do that. They've just accept the fact that might happen, but once we've proven that it will work. Probably the most useful thing in redesigning our service has been I think that document, the strategy that will fix healthcare, was really valuable at the beginning. I think linking in with other people who are doing it, because when you first start, it is a fairly new, even though it's been going for over a decade, it's fairly new in the implementation space. So it is, you quite often will find that you're standing there thinking, am I doing the right thing? Are we on the right track? Where are we meant to be going? But the advantage of working with other people and talking to them about it, you find, in fact, talking to people, you find that almost everybody has got to that point at some stage. You just get to it at different times. Sometimes you come across a roadblock or an issue earlier than others. So I found that probably one of the things I think we need to do better, and I think it's in healthcare generally, we probably needed to have better change management processes than we did at the beginning. We had them, but it's really hard to apply them consistently. And project management, we're probably not very good at that. I think in health, we tend to jump in and fix things really, really quickly. And when in fact, sometimes using the discipline of good project management, we might have not made some of the mistakes that we've made, jumped in too quickly.
I think the last thing I'd add to that, which was, we'll be honest, a little bit of a coincidence, was if we weren't doing the cultural piece in parallel, which we were doing as a separate piece, we didn't see it as value-based healthcare, we wouldn't have been as nearly successful in engaging the clinicians in the change and the vision.
Yep, clinical leadership is essential to it all, and I think every organisation is slightly different in the amount of clinical leadership it has, that's, if you don't have clinical leadership and engagement, then you need to build it. And so sometimes for some organisations that might be an issue as well. So the last question is, what would you suggest? How would you suggest starting a value-based healthcare initiative for dental services in a country such as South Africa, which does not support population medicine as yet? However, we have a large private sector based on fee-for-service and it's mainly curative. Look, most value-based healthcare doesn't have a population health component, although there's a growing number of people starting to consider it. So I think you can apply it pretty easily in just a clinical setting. Australia has also a very large private sector based fee-for-service, and it's mainly curative as well. But I think the model that we're setting up could apply in the private sector as well. But we're specifically doing it for a public setting, and we've got a large number of people a large population that we can apply it to. And I suppose the thing is that what I found interesting is I have been surprised how much support we've had from government and people, and I didn't think we would have, but now, only because I just didn't think they would be particularly interested, but we've found that we've ended up, once we started on the journey and started talking to people, we've had enormous support. So just start would be my advice.
And it's worth thinking about who the stakeholders are. So who are the payers in the system? Because they might be interested in supporting as well, whether that's public or private.
I know that we can't hear you, but we'd just really like to say thank you very much. Probably from a sharing point of view, before we end it, just like we found this journey to be a really exciting journey. We think it's the right thing to do about concentrating on improving health outcomes or bringing value to a health organisation. And we'd probably, and for people that are in the public health setting, it just totally rings true with a lot of the theories from a public health perspective. But even in a private health perspective, I think that in the long run, this will be something that people will have to look at, because I don't think our community can keep paying for that upward spiral of cost that we do at the moment. So I wish you all the very, very best with maybe starting your journey in value-based healthcare. We're also really happy to stay connected. If anybody wants to connect, we on the back of our email are our email addresses on the slide, the last slide. So very happy to contact us, and we will keep in contact.
All right, thank you to everyone who sent in their questions. As Deb said, if you think of any additional questions later on, and sorry we couldn't answer all of the questions, but you can contact Deb and Zoe through the details which were displayed in the screen earlier. We'll also send that in the email. So thank you everyone who joined us today. We will be posting the video recording on our website next week, and you will receive the link in your email. So we hope you can join us again in our future webinars. Next month, we have a webinar on hospital management in between the patient and regulation. We'll send more information about that shortly. Thanks again, everyone, and I hope you all have a great morning, afternoon, and evening ahead of you. Bye.